So the objectives of this talk includes reviewing the technique of transcranial Doppler, recognizing what normal blood flow patterns are, recognizing alterations in these blood flow patterns, and identifying applications for transcranial Doppler extending from as early as fetal life to brain death. Alterations in blood flow occur following asphyxia, trauma, subarachnoid hemorrhage, and there are many clinical indications, including sickle cell disease, vasculitis, hydrocephalus, vasospasm, AV malformations, and brain death. We'll start first with the fetal applications of transcranial Doppler. The technique includes obtaining axial images of the brain and with color Doppler putting the cursor on the middle cerebral artery. You can get various measures, including peak systolic velocity, pulsatility index, resistive index, and a cerebroplacental ratio, which includes the middle cerebral artery PI divided by the umbilical artery PI. What occurs during mammalian diving reflex? The heart slows, peripheral vasoconstriction occurs, and there is central nervous system vasodilatation. All these occur. Thus, when a fetus is in distress, you may also see cerebral redistribution, where you see increase in MCA diastolic flow, and this ends up increasing velocity and decreasing the PI. Looking at the MCA, one can assess fetal anemia with an increase in peak systolic velocity and assess for intrauterine growth retardation by looking at cranial to umbilical ratios, which decrease when there is cerebral redistribution. So with fetal anemia, peak systolic velocity can increase when there is significant anemia, and this is quite sensitive, though there is approximately a 12% false positive rate. There are numerous studies have demonstrated the reliability of looking at peak systolic velocities to assess for fetal anemia. For intrauterine growth retardation, one sees a decreased perfusion to the fetus. Thus, there is a redistribution of blood flow with increasing diastolic flow to the brain. When we deal with the cerebroplacental ratio, we're looking at the ratio of the MCA flow to the umbilical arterial flow. Typically, the ratio is over 1.45. This drops to 1 at about term. If the cerebroplacental ratio is less than 1, the suggestion of placental insufficiency should be raised. We'll now move on to the neonatal technique of transcranial Doppler. With the open fontanelle, we have the advantage of directly looking at the vessels as well as looking at the brain. Here we have a case of a vein of Galen aneurysm, beautifully seen by ultrasound. We can put the cursors on, demonstrating very high diastolic flow with multiple feeders into the vein of Galen aneurysm. Ultrasound can also be very useful after therapy. In this case, the infant has been embolized and we have successful obliteration of the vein of Galen aneurysm. We can also look not only at abnormal arteries, we can also look at the normal venous sinuses. With the linear transducer via the anterofontanelle, one can see the straight sinus, the vein of Galen. In this case, we do not see flow in the straight sinus, and this turned out to have a sagittal sinus thrombosis secondary to dehydration. So venous sinus thrombosis can occur in several different veins, including the vein of Labbé, vein of Galen, and these can develop hemorrhage. Therapy tends to be supportive. Rarely anticoagulation is recommended. In this infant on the right, we do not see any flow in the straight sinus, so it's important to know what normal looks like. Beware when we see vessels that do not have flow in them, and that it may not necessarily mean there's thrombosis. You have to be very careful with your technique to make sure that we're not simply seeing a very dilated, slow-flowing vessel. It's also useful with transcranial Doppler in the neonate to look at the subarachnoid space. Typically, there are crossing vessels, and this can help to differentiate simply extraaxial collections that are subarachnoid versus subdural. With a subdural hemorrhage or fluid collection, the vessels are going to be plastered along the convexity of the brain. You will not see any crossing vessels, and the gyri may be flattened. We'll now look at the intracranial arteries. Via the anterior fontanelle in the sagittal plane, one can see the anterior cerebral artery. The pulsatility can be again assessed with peak systolic and diastolic parameters, which then can result in ratios including the resistive index. In the anterior fontanelle, moving to the right and left in the coronal plane, one can insonate the middle cerebral arteries. Here's a case where you see no flow on the left with normal flow on the right, and on CT we demonstrate that there was an acute left MCA infarct. After fontanelle closure, we no longer have the luxury of visualizing the vessels directly via the fontanelles. However, there are several windows that are available to us even in the adult population. This includes the transtemporal window, the orbital window, the submandibular window, and the foramen magnum window. The transtemporal window can be utilized either with the imaging or non-imaging transducers. With the non-imaging transducer, one can place the transducer directly over where the MCA is coursing. With sound, one can establish various velocity patterns, including establishing the peak systolic and diastolic and time average maximum mean velocities. Advantages of the non-imaging transducers are that they are relatively inexpensive. The probe is small, so it's easy to manipulate. There's high quality sound, which is critical in making sure you're in the center of the vessel. These are made specifically for transcranial Doppler, so there are toggle buttons for moving every 2 millimeters, there's summary data sheets, and can be actually quite fast in experienced hands. Problems with the non-imaging technique are that it does require intensive training. It may be hard to find the vessel simply by listening for it, and many centers do not have this machinery available. With imaging, where most radiologists now have ultrasounds that can give us both color and grayscale Doppler via the transtemporal approach. By throwing the color on, we often can see a beautiful circle of Willis. The first arrow is pointing to the left middle cerebral artery. One can see the anterior cerebral artery, the posterior cerebral artery. When you put the cursors on, you can get a Doppler signal that again gives us information including peak systolic velocities and diastolic velocities, resistive indices, pulsatility indices, time average maximum mean velocities. With the vessel coursing towards the transducer, the strongest signal comes from the middle cerebral artery. And you can march down this vessel every 2 millimeters to make sure that there are no areas of stenosis or narrowing throughout the vessel. At the level of the bifurcation, one gets flow away from the transducer, which is the anterior cerebral artery, as well as flow towards the transducer, which is the middle cerebral artery. This gives you a biphasic wave pattern, which in this case is the bifurcation. Angling slightly anteriorly and a little more distally, one gets flow in a reverse direction, and this is the anterior cerebral artery. If you angle the transducer inferiorly slightly, one can get portions of the distal internal cerebral artery, which has a slightly harsher pattern and sound. And when you angle posteriorly, one can get portions of the posterior cerebral artery. The velocity of the posterior cerebral artery tends to be somewhat lower than the middle cerebral artery. Going from the posterior approach, one can identify the basilar artery and the vertebral arteries. One can also view an orbital window and get ophthalmic dopplers. So the ophthalmic artery also gives a typical waveform pattern. It's a slightly higher resistant vessel. However, when there's collateralization, one has increased flow in diastole and can help support the diagnosis of an internal cerebral artery stenosis. In this case, we have MR documentation that the ophthalmic artery is being used as a collateral due to narrowing of the distal ICA. So what are advantages of the imaging approach? Well, one can actually see the vessel, so quickly place the gate with higher confidence of what vessel you're seeing. It is a shorter learning curve, and most radiology departments have these transducers available. One can auto trace and, if necessary, can angle correct.